poi diamo inizio alla seconda sessione. Grazie.
Good morning, everybody. We will invite Dr. Lee to speak about the topics of ptosis.
I am not a surgeon, so you will not be hearing anything about cutting from me. But my dad would say, a good surgeon knows when to cut, but a great surgeon knows when not to cut. This talk is recognizing the red flag, the red herring, and the red alert that should make you say, no cutting. No cutting. So when should you be a cutter who doesn't cut? I have these disclosures. They have nothing to do with today. But at the cocktail party, you can ask me what we do for the National Football League. Our football's a little different than your football. The United States Department of Justice and NASA. In 1978, I wanted to be a doctor. You can see which one of those guys is me. My second choice was to work for NASA. My third choice was Jedi Knight. So here's the patient. They have what looks like to you to be a droopy lid, and you're ready to cut. They got a high and distinct lid crease. It looks like levator dehiscence. And so what you should be asking yourself is this neurop? Because if it's neurop, don't cut. The timer didn't start. Can you restart the timer? So I'm asking you for a behavior change. I care what you write in your evaluation because I want to come back to Amalfi, but I care more about you and your patients. Impression, ptosis, left eye, plan, scheduled ptosis repair, and I'm going to post their photograph after surgery. That works in 99% of these people. But there's this 1% of people where the answer is don't cut. And one of those is you lift up the ptotic eyelid and they say, I have double. Don't cut. You lift up the ptotic eyelid and the pupil is bigger. Don't cut. You lift up the ptotic eyelid and they say anything other than that looks great, don't cut. So you should not cut on any ptosis with anisocoria, and any ptosis with pain, and any ptosis with an RAPD, and any ptosis with ophthalmoplegia. The most common cause of this presentation right here, a ptotic lid with anisocoria and painless or painful, is aneurysm of the posterior communicating artery. It is the rule of the pupil. People like me stood up here and told you, you would look at the pupil, and if the pupil's not involved, you can wait. You cannot listen to me of the past. This is not your father's third nerve palsy. Any third nerve palsy needs CT, CTA, an angiogram, followed by MRI, MRA. I'll just say it again. You must image all third nerve palsy ptosis. There is no A in MRI. You need an A to find the A. The A we're looking for, aneurysm. The A to find it, angiogram. You need to have a CTA or an MRA, some kind of A if you have third nerve palsy. 1 in 50 people has an aneurysm. That means somebody in this auditorium is harboring this aneurysm right now. So look to your left and look to your right. If you can't figure out who it is, it's you. Don't fall for that red herring. The red herring in this case is diabetes. It does not matter whether the person has diabetes or not. Diabetics get aneurysm just like everybody else. Do not fall for that red herring. The red flag, any combination of lid and pupil is bad. Big pupil, big ptosis, big problem. That's aneurysm. Little pupil, little ptosis, also big problem. That's the Horner syndrome. Big ptosis, little pupil, that's aneurysm. Little ptosis, big pupil, that's aneurysm. 3 of the 4 combinations of lid and pupil are aneurysm. And what you're looking for is this aneurysm here, the posterior communicating artery aneurysm. If this thing ruptures, half the people just die at the scene, never make it to the hospital. Of the people who make it to the hospital after the rupture, half of those people will never return to independent living. However, if the aneurysm is diagnosed before the rupture and it is coiled or clipped, go home hospital day 3. And you are the hero of this ptosis story. Do not cut on lid and pupil. Do not work this up by yourself. You must phone a friend. You cannot DIY, do it yourself. If you DIY this, they will DIE. You need to work this up as a team, and that means when you leave here, you better find a friend and phone that friend, and that friend is neurology. Here's another case. They're PERLA, pupil equal round reactive to light and accommodation. But PERLA is not the same as normal. Yes, they have a high and indistinct lid crease. Yes, it's bilateral. Yes, you just want to operate this. Don't you just want to cut on this? I know Kirsten wants a knife in this. But you must check in the light and the dark. PERLA, pupil equal round reactive to light and accommodation, has no assessment of the dark. Do you see the wolf in the anisocoria in the dark in this bottom frame? You are about to operate on a Horner syndrome. So, any anisocoria in the dark, even if it's little ptosis, and little pupil, that's a carotid dissection until proven otherwise. So an acute, painful, little pupil, little ptosis, big problem. So here it is in the light. You can see you're ready to cut on this person, but look in the dark. You see that little bit of anisocoria? I guarantee you that in your busy oculoplastics clinic, you are going to pass over that patient. Maybe the technician is the one that actually checks the pupils in your clinic. And if you let them write PERLA, they are not doing a complete exam. It should be PERL-DUH. Pupil equal round reactive to light and no anisocoria in the dark. PERL-DUH. But you're stuck with that PERLA. And here we've given aproclonidine. Aproclonidine is a sympathomimetic. You can see that it reverses the anisocoria in a Horner syndrome because it has differential effects on alpha-1 versus alpha-2. This proves that this is a pharmacologically confirmed Horner syndrome. And guess what? You didn't operate this. You didn't cut on a Horner's, and you saved them. You saved them by not cutting. So in order to see the light, you have to look at the pupil in the dark. And that means an oculoplastic surgeon who is so busy taking pictures of people's ptosis, you got to turn the light down a little bit and look for this anisocoria. The other thing you need to know about is this upside down ptosis. The gravitational field of this planet only works one way. Everything's got to go down. Sagging eye, sagging face, sagging lids, sagging breasts, sagging muscles. Everything goes this way. If the lid is going up, that can't happen. That is upside down ptosis. That is a neurogenic finding. It is the most under-recognized finding in the Horner syndrome. So you can see little ptosis, little anisocoria, but upside down ptosis in this 45-year-old male with neck pain after a motor vehicle accident. Do not fool around with this. This goes to the ER. CT, CTA. For Horner's, you must image the entire pathway from hypothalamus all the way down to thoracic T2 in the chest, back up into the carotid. And the thing we're worried about here is carotid dissection. You don't need to know any of that. You just need to know not cutting today. No cutting for upside down ptosis. No cutting for anisocoria. Go away. If it's a kid, don't cut this. If it's a kid, you must work it up first. Of course, it could be congenital ptosis. You saw in the previous speaker some wonderful examples of congenital ptosis. But do you see the upside down ptosis now? Do you see now that you've been trained to look for it? You will see it. And that anisocoria, you would totally blow past that. If you've got the big pupil and the big ptosis and the thumb sign lifting the lid, nobody misses this. The janitor at my hospital knows this is an aneurysm. So you have to be at least as good as the janitor at the Methodist Hospital in Houston. Any degree of third nerve palsy, however, is red alert. That means partial palsies. The lid is halfway down. Partial ptosis. Partial pupil. The lid is down a little bit. The pupil reacts a little bit, but not completely well. All of those are red alert. Do not fool around with these. CT, CTA, rule out aneurysm in every third nerve palsy. Do not watch that person and don't fall for that red herring, the diabetes. If they're immunosuppressed or they've had a renal transplant, even if the pupil is fixed and dilated, you must swing the light for an RAPD. If there's an RAPD and you have a 3, now you have a 2 and a 3, that pushes the lesion right into the orbital apex. And in a diabetic, that's mucor, especially if they're immunocompromised. So you can test for an RAPD even if you have a fixed and dilated pupil by looking at the fellow eye. This is called a reverse RAPD. So even if it's a fixed and dilated pupil, you must still swing that light, and it don't mean a thing if you don't do that swing. You have to swing that pupil. This is a huge red flag. Pupil defect plus anisocoria puts the lesion into the orbit, and in immunosuppressed people, it's almost always an infection or infiltrative or something bad. There's nothing good that causes a combination of RAPD and third. So these are the 5 things I want you to take home when you're asking yourself, should I cut? You're going to hear my voice say, don't cut. Don't cut ptosis with anisocoria. Don't cut variable and fatigable recurrent ptosis. Don't cut diplopia ptosis. Don't cut aberrant regeneration. And don't cut painful ptosis in elderly people, that's giant cell or aneurysm. I told you I wanted to be a doctor. I wanted to work for NASA, and I wanted to be a Jedi Knight. It turns out I get to do all 3. And I thank you for your time and attention.
Thank you very much, Dr. Lee. I'm now presenting Dr. Ascolini. He started with the ptosis repair using open neuroectomy.
Thank you, Luigi, for this honor invitation. It's very nice to be here. I would like to talk about ptosis repair using an open sky milirectomy. This technique is not so used. And I will start talking about the Fasanella cerva. Was described in 1961 for resection of the elevator, tarsus, and conjunctiva. And they told about this is a quick procedure, but in 1975, Putterman and Wrist, they described a special clamp for surgery, and in this variation of technique, they removed just conjunctiva and Miller muscle. There is some papers from Cochabert group, starting in the beginning of the 2000s, about an open sky Miller muscle conjunctiva milirectomy. They suggest to put local or general anesthesia to cut the conjunctiva and Miller muscle near the superior portion of the tarsus, doing a flap of conjunctiva and Miller muscle, removing this flap, and then suturing, and they use to suture the silk 6-0. About their studies, they suggest this technique is very nice for moderate or good elevator function, is safe, effective, and it could be done for phenylephrine positive or negative. The surgery is open sky, Miller muscle conjunctival resection. Remember this. Here I will show a movie. How can I pass? Dr. Hidalgo gave this for me. Is open sky conjunctival milirectomy. She is cutting the conjunctiva. I love the videos from Dr. Hidalgo. She used a simple clamp, and here you see the Miller muscle and the conjunctiva. It's very easy to see. Measuring around 80. For this surgery, no need special algorithms. And cutting the conjunctiva and the Miller muscle. And she was using here the Proline 6-0 to suture this flap to the tarsus. I think it's much easier than to put the Putterman clamp. It's easy to see, easy to suture, everything. But when we remove the conjunctiva, there is a lot of studies showing we can remove also the wolfram glands and the Krause gland, and also the Goblet cells. This study proved the amount of Goblet cells after the surgery is reduced too much. Even with reduced Goblet cells, we cannot have dry eye symptoms. They proved this in this paper. And there are a lot of papers showing using different kind of tests. Here they use the Schirmer test and the questionnaire. Here they use the Schirmer test, the breakup time, fluorescein and photobengal. Here they use also measurement of the layer, lipid layer, and tear osmolarity. And here they use non-invasive methods to study the tears, like mebomography, viscokeratography, and all those papers showed removing the conjunctiva and conjunctival milirectomy. We do not have dryness. But in 1975, Durzbach, 1979, Durzbach showed this kind of technique. He separated the conjunctiva and the Miller muscle and removed just the Miller muscle. And here you can see in the second picture, the Miller muscle dissected and removed just the Miller muscle and closing the conjunctiva. The group of Cochabert called this isolated Miller muscle resection, and because we don't remove the conjunctiva, and they provide a lot of information about it. It's very nice to remove just the Miller muscle, and the suture you can put around the crease with no concerns about the dryness and the full weight of the fornix. You don't reduce the weight of the fornix. Here I show you a video. We need to put suture, silk, and turn the lid and put local, not too much because you can start. Cauterize the conjunctiva. And you cut the conjunctiva, and then you will separate the Miller muscle. You cannot put the point. You separate the Miller muscle from the conjunctiva, and then the Miller muscle from the levator. If you are accustomed with the posterior approach, this is easy. Here, separate the Miller muscle from the levator. The amount that you remove is 8. They say no need to change because it's for moderate doses or. You see the flap, and then cut the flap and pass the suture. We are using 6-0 Vicro, passing the suture between the 1 or 2 millimeters of Miller muscle that stay there because we remove 8 millimeters. And then you close the suture. We are very near the white line. It's easy to see the white line. This is a mark for us also. We put one suture in the middle, and we see if it's fine, we just do one suture, or we can do 2 or 3 sutures. Here another case, another movie. Can you pass for me, please? The same. just to show what I'm doing with the conjuntiva when we finish. Because Dortzma suggests to close, Cochabed suggests to close the conjuntiva, but we are not closing. The Miller muscle is bleeding, huh? Because there is a lot of vessels in the Miller muscle. It's necessary to cauterize. You can see the white line. And the flap now, removing from the conjuntiva, separating the Miller muscle from the conjuntiva. And then we will cut 8 millimeters. Here the measure is not possible to see in the movie, but I measure. And putting the suture, Vicor 6-0, can be double armed or no. If it's not double armed, we need to go back. Checking if it's fine, if it's not crossing the tarsus. And then remove the mark. Just testing. This can be done with or without blepharoplasty. If it's fine, not. And then we'll put the conjuntiva in the place as we usually do, the same that we usually do in the white line, without suture. Advantages: direct anatomical visualization, no need complex algorithms, intraoperative adjustment of eyelid height is possible, do not remove glands, do not remove conjuntiva, the cul-de-sac stay the same, it's a surgery that is easy and predictable. Thank you very much for your attention.
Thank you very much. The next presentation is in charge of Dr. Juan Pablo Aldecoa from Argentina. Very good friend.
Thank you. Thank you very much to Luigi for the invitation at this Congress and the spectacular organization.
Sound, please.
Okay. I know. Okay. Thank you, Luigi, for the invitation at this Congress, and a special memorizing to Daniel, our mentor and teacher. In the few next minutes, I talk about aponeurosis ptosis surgery, only aponeurosis surgery, and which is the best option in these cases. The ptosis surgery is the surgery that identifies a oculoplastic surgery, in my opinion. It requires a deep knowledge of eyelid anatomy. Due to its multiple etiologies, it opens to the door to many differential diagnoses. And it is always a functional and aesthetic challenge. For beginning, I chose this case. It's a female, 48 years old, with a ptosis with good elevator function and dermatochalasis. The margin reflex distance 1 in the right eye is 2 millimeters and the left eye 3 millimeters. And the fertility test is positive, and which is the best option for you. Perhaps is very different opinions in this moment for us. Anterior or posterior approach? Well, my choice was an anterior aponeurosis reconstruction and upper and lower blepharoplasty. But I like to make some considerations about the aponeurotic ptosis. In the evolutional cases, the characteristics are high eyelid crease, good elevator function, and in general is present in the middle-aged people. This is the anatomical appearance of the aponeurosis, and in a picture with an intact aponeurosis and another with an aponeurotic dehiscence. We can see the Mueller muscle through the dehiscence of the aponeurosis. There are several cases, the ptosis correction using combining techniques, anterior and posterior approach, blepharoplasty and cantoplasty. In the traumatic cases, this case shares characteristics with involutional ptosis, but occurring in younger patients, isolated or in context of fascial trauma. The characteristic of the aponeurosis is very, very normal. It's a normal aspect of the aponeurosis, the elevator aponeurosis, but with disinsertion of the tarsal plate. We only reinsertion to the tarsal plate. Another cases is the cases of the mechanical or aponeurotic ptosis. These cases is due to recurrent and chronic trauma, especially in users of contact lens. These patients put off the eyelid at the moment of the insert or remove the contact lens, and produce a partial deinsertion of the aponeurosis muscle. This is variations in the involutional ptosis with a dehiscence aponeurosis. In the traumatic ptosis is a normal aponeurosis, but with the insertion of the tarsal plate, and the mechanical and repetitive trauma, traumatic ptosis, is a partial the insertion of the aponeurosis with this aspect. The aponeurosis, surgical and involutional ptosis is a very, very classic reinsertion aponeurosis. It's important the dissection of the descent aponeurosis underneath the fat, the preaponeurosis fat, and reinsertion, and then requires in general the check in the intraoperatory position. We remove the corneal protector and then the position of the open eyelid. In the posterior approach, we infiltrate the conjunctiva Mueller plane with phenylephrine, with anesthesia, and dissection 1 millimeter for below the inferior border of the tarsus. I prefer to use this cotton tip for a traumatic dissection of the plant, and find the white line and proceed to reinsert this white line to the anterior face of the tarsal plate. It's important to do this suture 2 or 3 millimeters in the anterior face for avoid the contact of the suture with the ocular surface in the postoperative time. In this picture, you read the most important steps in this procedure. This is cases of ptosis correction using the posterior approach, in general in older patients that not requires another aesthetic correction. Is only for to open the eyelid crease, and in general are patients with increased risk operative. It is cases when combining the dermatochalasis and ptosis, and we perform blepharoplastic surgery with anterior or posterior aponeurosis surgery. The last year we present a paper in the Archivos de Sociedad Española de Oftalmología, then evaluate of palpebral opening after reinsertion of the elevator aponeurosis with anterior and posterior approach. We see 62 eyelids, 34 patients, 50% anterior approach and another half posterior approach. And the results in comparison with ideal condition for the eyelid opening is 4 millimeters the RMD1 or 10 millimeters an eyelid aperture. We found that 30% the patients with anterior approach was more optimal corrections and less variability in outcomes, and in comparison with the 20% with posterior approach. The most relevant point is in the results is the anterior approach is more precise and ideal condition. The posterior approach presents lower variability and less risk of overcorrection. The anterior approach avoids more flexibility in cases of simultaneous procedures. The shape of the eyelid is more homogeneous in the posterior approach, and the anterior approach presents a lower tendency to undercorrection over time. The anterior approach provides direct visualization, can be addressed simultaneously with another procedures, and high stability over time, but is a procedure technique dependent. The posterior approach is present as surgical time shorter in comparison with the anterior approach. It's necessary to visible scar, and it's more predictable and natural contour of the eyelid, and in general no required intraoperative control and check intraoperative. So in anterior and posterior approach, both techniques are effective, both have supporters and detractors, both can file EPOR and EPAR correction, but the difference between a good outcome and a revision procedure or necessity of reinterventions depends on the surgeon initial decision. So, which is the best option in the best approach depends on the clinical assessment, anatomical features, the possible need to combine procedures, overall the surgeon's experience and comfort level. Thank you very much for your attention. I'd like to invite it at the Bienal Congress in the Mendoza City in Buenos Aires, the next 30 and 40 in November of this year. Thank you very much.
Thank you, Dr. Oliveira. And I invite now Dr. Cardoso Pereira, Ivana Cardoso Pereira, to talk about frontalis transfer. Dr. Ivana is the president of the Oculoplastic Society, Brazilian Oculoplastic Society.
Thank you so much. Good morning, colleagues. I'm Ivana from Brazil, and I'd like to thank you, Luigi and Daniel, to be here at this moment. And I will talk about. I want to discuss a procedure, not just a procedure to correct the ptosis. I'd like to talk about one thing. I think it's a paradigm shift to restore both function and cosmetic result. I will talk about frontalis transfer. Then, like Ana Rosa said today, studies have demonstrated a diverse psychosocial and mental health disorders among children with eyelid disorders. And then we know that children with ptosis were 2.5 times more likely than control group to develop mental illness and twice more likely to develop a psychosocial maladjustment. We are not treating just eyelids. We are treating anxiety, we are treating major depression, we are treating alcoholism. And a mental illness was diagnosed in 38% with eyelid ptosis, compared with 20% in control group. Timing is everything in ptosis, the treatment of ptosis. And we join a timeline. Like a more or less 1 year old, we think about we just to prevent the amblyopia. At 4 or 5 years, we have psychosocial disorders in these children, and for 10 years, we think about aesthetics. Then the frontalis transfer is based on recruitment of the frontalis muscle, is indicated in cases of insufficient or absent poor levator function. And to know the future, you have to study about our history. In 1901, Fergus described frontalis flap description, the first description of frontalis flap. He did incision above the eyebrow to connect that. Then Pear and Wright studied so much about fascia lata. And then mid-20th century, refinements of materials and surgical techniques were done. In 1982, Song described a direct frontalis muscle transfer to the tarsus. And it was a paradigm shift from a passive suspension for a dynamic reconstruction. We created one vector to do this connection. And in 2014, Ramon Medel refined that. And he shows for us the use of this technique in early frontal flap surgery as the first option in congenital ptosis treatment. Then he used a direct force with an active muscle transfer. It's more physiological than using other materials. Then the frontalis muscle, we have to know that the innervation is about a frontal branch of the facial nerve. The action of the frontalis muscle is to elevate the eyebrow, and the surgical concept is to create a new elevation vector. It's more vertical and anterior, but we do this other vector. Then I will show a short video. We do the incision, and then we detach the frontal muscle at the subcutaneous plane. It's important to detach it wide. We go about 1 or 2 centimeters above the eyebrow. It's very important to do that. And we have to do a wide horizontally flap. It's very important. And for this, then where you are. Then you make the sutures. We do 2 or 3 sutures, and you can use 5-0 Proline or 5-0 Merceline. We were doing with Merceline, now we are doing just with Proline. And you do 1 U suture to connect that, the flap to the tarsus. Here I'm doing another suture. And then you do some false notches to see if the height and the contour are well to do that. Here I'm looking if it's transfixed or not. And here turning to the flap to do our U suture. Here we will check the height and the contour, like I said, and then it's very important to do one pass. It's very important to do. We have to anchor the sutures because the fibers of the frontalis muscle are vertically, and to prevent one undercorrection, we have to do this anchor. And for do that, we go back and forth to the flap and give this the suture. Then we create a lid crease. You have to do skin, frontal muscle, and skin again. It's very important to do this pass too to prevent lash ptosis. And then we close the skin. I think the results talk for us everything. And here there's a boy with 20 postoperatively. Here, 7 years after the surgery, we can see the stable and the symmetry of in this case. It's another case. Here is a child with 5 years old. She has a poor function. We leave here we have the reductive aspect. We leave the eyelid 1 or 2 millimeters above the cornea, and after 12 months or 1 year, she has a good blinking and a good eyelid closure. Here another case. It's a child with Möbius syndrome before the surgery, 2 months after the surgery, and 6 months after the surgery. And the last case is one preoperative after 2 resections, 2 failed resections. I did a bilateral frontalis flap, and she is after 5 days. And here, after 4 months, when the man sent to me this picture and said for me, "Good morning," with the most beautiful smile. I think is why we do what we do, is like to receive like something like that. Then the indications are clear. We use this technique in poor levator function, in congenital ptosis, blepharophimosis, Marcus Gunn's jaw winking, third nerve palsy, severe myogenic ptosis, reoperations. You can use that. And some people are saying there is a limitation at this technique. I don't think that. We create one different vector because the vector of the levator muscle are more posteriorly, and when you create this vector, you do it's more anterior. But I think we have some variations to correct that. One was described too for Ramon Medel, and he described Pulley with levator aponeurosis in patients with deep set eyes. It's very useful to do, and it's very important to do that to prevent poppy eyelid. It's very good to do that. Then other other papers, Richard Allen described he is doing a combined elevator, the elevator and the frontalis muscle to recurrent severe congenital ptosis. And Don Kikawa and Bob Corney compared these two. Here we are showing, we have an anterior flap in the first picture. We have a red flag there. It's created by frontalis vector. Then in the B, we have a posterior vector, the elevator muscle. And the C, you can see one intermediate vector uniting frontalis and elevator muscle to do this. But in properly this study, they had a very good results with both techniques, with doing the intermediate vector or not doing the intermediate vector. Then the advantage of this technique, it's a single site, we have a low morbidity, we have a no foreign body reaction, we have a good contour, and this result is stability. For advanced, I think the surgeon requires good anatomic knowledge, a steeper learning curve, and we have a great corneal protection than other techniques. To conclude, we pass from a passive suspension to a dynamic reconstruction. It's ideal for poor elevator function. We have excellent functional and aesthetics outcomes, and it's technique dependent, it requires precision, and it's a very reliable long-term use results, even in complex cases. I'd like to thank you, Luigi, my mentors that are here, Silvana Stellini and Susana Matayoshi, and especially Ramon Medel, who shows me this technique. And I see you in Brazil in June. It's a very good conference of that, and I would like to see you there. Thank you.
Thank you very much, Susana. To continue, let me introduce the world champion of the congenital ptosis, Dr. Ramon Medel. His title is BPS surgery, the state of the art. Thank you, Ramon.
The world, okay?
World champion of congenital ptosis.
Come dici in italiano?
My opinion.
Can you show that my computer, please? No. Okay. Well, I'm going to explain you my philosophy when I face a BPS patient. And of course, every one of you know what is going on BPS, and I'm focused on two things. One thing is the picanthus, and in my mind is to leave the less scar possible. I hate the scars. I hate marks. I want to hide every mark of mine, even in a blepharoplasty, even in a tumor, but in this is mandatory. Improve the intercandal distance, and you can use the epicanthal surgery as first as classically is done. It was done. When I think in ptosis, sometimes if you are thinking that the patient has amblyopia, probably you have to do ptosis first. And you have to use the less scar possible. Frontalis flap is best on that. Less complications, frontalis flap is best on that. And more durable, and frontalis flap is best on that also. So this is my technique, and I have done, you will see some numbers, but I think it's a technique that makes a difference with the past. And the most important thing, what to do? We can manage to do nothing, no surgery. It's an option. So no need to do something, sometimes to do anything. We can do first epicanthus, we can do first ptosis, or we can combine epicanthus and ptosis all together. When I think in BPS, probably some of you don't know, but BPS patients are lovely, and they are so clever. They are smarter than the media. And they look as syndromic. And we have to change this syndromic appearance. And syndromic appearance is about proportions. The proportion is between intercanthal distance and the eyelid fissure. With any congenital ptosis, we have this asymmetry of proportions. Proportions are more or less equal in all patients, but in those patients we have this. And we have to improve this. Sometimes, if we are in adult, this is my son. And the proportions are more or less good, but in adults, we can measure very well. But on kids, it's not easy to measure. And it's very difficult to do studies on children because they are growing up and it's very difficult to measure. This one case we did only frontalis flap, and this is the result some years after. This is a patient that we did 2 steps, first epicanthal and second the frontalis flap, and some years after. But nowadays, the big majority of patients, we are doing everything together. We started with an Brazilian baby that they asked me, please, we cannot come back to do the second surgery, so why don't you do? And the result was so good that we improved it. We tried to repeat this. And what about epicantoplasty? For me, the most important thing. So frontalis flap is changing the ptosis, but on BPS, epicantoplasty is very important. It's about changing the syndromic to non-syndromic phase. And it's very important to change these proportions. And that's why we describe this technique, lambda double fixation, some few years ago. And I want to explain you why we think on that technique. We have several techniques for, we have several techniques on the historical set plasties, most of the techniques. But I did a study in Morpheus, like when I was there 30 years ago, in 100 cases of BPS. Richard Cullen asked us to see what was the best technique, or more stable technique in ptosis at that time. In the historical files of Morpheus, 100 patients, and the best was the B2Y incision. And nowadays, there are another technique that I like very much, which is the redraping technique, because the incision is less and it's small, and we can achieve the same. Why to change to lambda? So, which is this tiny thing, tiny cut in the upper corner. Why to change this? I don't want to be famous, but this is a thing that is important for us. Why is lambda double fixation like this? First, it's less scarce than the big majority of techniques. There's a better approach to the upper canthal area, and this is important because we have to develop the fibrous adipose tissue there, and it's very important, as you will see afterward. So we can work better in the upper part of the medial canthus. And there is no interference on the new skin crease. If you operate any BPS patients, the skin is thick and the upper lamella is short. And if you have a scar there, it's impossible to create a new skin crease medially. And this is critical for the evolution of the cases. So this is very important. With this tiny incision, we can do true fixations of the medial canthus, which makes more stable, and is, in my opinion, better stability. When we do this, we are improving the epicanthus the telecanthus, but with this technique, we can improve the concavity of the medial canthus, which is a human spot. It's very important. And if you see the difference in between the one side to be operated and the second, the concavity of the medial canthus is very important. Some moms tell us, "Doctor, what did you to the nose?" I did nothing on the nose. We just create the concavity of the medial canthus. It's very important. Some cases, you have here, pre and post, in one step. One step. This is the lady from Brazil that changed to do everything in one shot, one operation. Is she BPS or not? It's BPS. It's a big change. So, how is the evolution of this technique? It's difficult to measure. The kids grow up, so it's difficult to do a study and to know if it works or not. I'm sure it works. For example, in this case, we have an intercanthal distance of 32, and we moved to 23 in 1 year, and keep it stable. You see the difference. Preoperatively 41, final operation 23, and no measurements, because we have no control of those patients that are from abroad, and it's very difficult to measure, but this is the result. So I guess 30, 30, 30, or something like that, like you and me. 42 to 25, and really stable 1 year after, without measurements. But we started doing this operation 3 years ago, and we have these measurements from one of the first cases we did with 3 years of evolution, and we can see that we improved was a very severe case. We improved the intercanthal distance, and it remains stable, and the proportions remains stable. So they look not asyndromic. It's not perfect, but looks not asyndromic. It's difficult to study. In the last 3 years, we received like more than 900 congenital ptosis. We did almost 1,000 in 3 years. And 127 BPS cases. So it's a big numbers, but the people came to go, and it's difficult to connect and to measure, to do a proper study. We are working on that in order to show you all the details. But when we face blepharophimosis, it's not only phimosis, ptosis, and epicanthus. There's a lot of variations and things that we have to think that are not written down on the books. For example, euroblepharon. Euroblepharon is really common on BPS, and it's very difficult to manage. And if our work is completely different if it's euroblepharon or not. Phimosis is completely different in every patient. Nobody talks about the lateral canthal laxity, and I guess near 100% has laxity of the lateral canthal tendon on BPS. Nobody talks about that. Nobody spoke about the anterior lamellar insufficiency. So skin is shorter in the upper lid, and every patient is different, and the muscle is shorter. So there are more difficulties in some patients. And nobody spoke about the paradoxal tarsal blade. What is that? That is, if you operate a BPS, the tarsal blade is shortened horizontally, but it's not shortened vertically. And sometimes are larger than normal vertically. in some patients are, and we have to manage this because in order to set the good setting of the eyelid. So this, we saw that very commonly. Nobody talks about lacrimal gland, lacrimal production, but we have here, we are very lucky because we have here Antonio Velasco Cruz and Patricia Caixi that did a tremendous, important work that changed the behavior on every BPS patient. So I want to thank you so much, those friends. And nobody spoke up on the bone distance, the lacrimal crest bony crystal distance, because sometimes there are patients that looks like BPS, and we face that there's a bony enlargement, and those are what we call BPS-like. The treatment is completely the same, but we have to know. And this is what we call BPS-like. Like this baby. Looks like BPS, but it's not BPS. It's a syndromic case, and of course we did bilateral flat, frontalis flat, bilateral lambda double fixation, and this is the result on this case also. It's a unilateral case, but we did bilateral surgery. You have to hear this a lot because this is the future. It's not the future, it's the present. Because it's bilateral. It's a bilateral problem. So, regarding the lacrimal gland, this is the paper. So, Patricia and Jose Augusto, Antonio Augusto, in 21 cases, 42% no lacrimal gland bilaterally, even 10% no lacrimal gland unilateral. So this changed dramatically for us. So because we cannot be aggressive on those patients because they've got dry eye. And sometimes we have had a lot of chemosis after the BPS. It's a long surgery. It's a 3 hours, 2 hours and a half, 3 hours surgery, and we have chemosis. But we find people like this. When we study, no. I asked for 3 more minutes, my friend. This is a prolapse of the lacrimal gland, and that is the cause of this ephimosis. And on those, we have to deal with flat faces, and on ptosis we face with deep set eyes, which is more difficult. But on children with BPS, we have to work with very small structures. So it's more difficult to surgeons, but read this sentence. The indication is when the patient needs it, not when the surgeon is prepared. Think on that. Well, I want to just one more minute. I missed yesterday all the thing on Daniel, but I want to I'm going to say in Spanish this. This is very important to me because 1 year and a half ago, Luigi and I, Luigi asked me to do the meetings together because 2 things. One is because a lot of people from America used to come, and are different ways of meetings. This is more theoretical. My meeting is practical, surgery, life surgery, big surgeries, difficult cases, and we asked to be together. So, and that's why next week we will have a meeting in Malaga, and we want to receive you all. And the second question, the second thing why we try to do it together is because Daniel was in a not very good time. And Daniel is a person that has a big influence on Luigi and me. And we spoke about to stimulate Daniel to improve, to come. He was so happy to come to this meeting and to my meeting. to Italy. He loves Italy. He loves Italy because Italy treats him very well. In Spain, they treat him. Some people, some important people, oculoplastic surgeons in Spain, treat him really bad. And but he wanted to come to my meeting. And regarding Daniel, so many things, so many meetings, operations, so many life surgeries. I want to show you this picture. It's very important. This was the first time I went to Lima to do a big number of frontalis flap, and I invited Daniel in order to show him the procedure, in order to try to have some incomes to him, because it was so generous to anyone. And he did nothing. Just come back to Argentina and teach everyone of their team how to do it, how to improve, give everything. So he was always, how many times ago? I don't know, 20 years ago, something, here in Rovelo, 20 something years ago. Luigi? 20, 20 años, hace 20 años. He loves pitch. Was the most generous person, giving everything he knows. And this is a really strange kind of person. And this is in Esaso. Every time we invite them in Esaso, he was the last one doing with the cadavers, and all the students there around. And Daniel, we have to go. Wait. And he was teaching. He was so enthusiastic with young people, transmitting people. And yes, was a torero. It's a torero. It's not because he loves bullfights. It's another meaning. Torero is, in Spanish, llevar tu pasión al límite en busca de la pureza, a costa de la vida. Y ese era Daniel Guayo. Es su frate, es mi hermano. Y bueno, solo decirles que él era feliz en esta tierra, que Eva y Blanca están por aquí, que ellos saben que aquí fue muy feliz. Y aquí tiene muchos amigos que éramos como hermanos todos. Y donde esté, siempre le voy a dar las gracias a la vida por haberme cruzado con él. Gracias.
Thank you, Dr. I would like to invite Ana Duarte. She will speak about the eyelid doesn't lie, challenging cases of eyelid retraction.
Hi, good morning. It's really an honor. Thank you, Luigi, for organizing this amazing meeting. It's really an honor. And so I'm discussing today challenging cases of eyelid retraction and how identifying the underlying mechanism help us how to guide the surgical correction. And on the contrary of what Dr. Lee presented, we will see a lot of cutting. So you see these different patients, but they have something in common. All of them have an acquired form of eyelid retraction. And don't forget that eyelid retraction is not a diagnosis for itself, it's a clinical sign. It's a clinical sign of something else. You should approach it the approach should always be diagnosis driven, and don't forget that many cases are multifactorial. Now, what are the main causes of eyelid retraction? There are many causes that change when we consider the upper and the lower eyelid. Just let's go through this really quickly. So the upper eyelid, usually we consider an upper eyelid retraction when we see a patient with more than 5 millimeters of MRD1, and we always think about thyroid eye disease, of course, then overcorrection after ptosis surgery, but there are so many other causes, neurogenic, cicatricial. Now the lower eyelid, consider, and usually this is much more common as a cicatricial mechanism, whether after trauma, infections, lower eyelid blepharoplasty, of course, eyelid reconstruction, then other cases that we see quite often of facial nerve palsy and also some anatomic features that do cause some lower eyelid retraction. Now, why does eyelid retraction occurs? And let's divide it in two mechanisms. So there are too many main mechanisms, and let's make them guide us through our decisions of how to operate these patients. So we can have either vertical tethering forces that pulls the eyelid, whether the upper or the lower, or we can have the loss of support structures, and this specifically in the lower eyelid. So the lower eyelid descends. Now, let's start with the first one. It's quite complex. Vertical tethering forces. So we usually see these cases as having a cicatricial mechanism. And when we see these patients, don't forget about anatomy, of course, anterior lamella, posterior lamella, and usually as oculoplastic surgeons, we usually discuss a middle lamella, which is the septum, and as a possible cause of eyelid retraction. Either way, knowing where is the main cause for the scar, where the scar is located, is very important for us to decide and go through our algorithm of treatment. Now, again, how can we treat either of these causes? So, again, consider anterior lamella, middle lamella, posterior lamella. So, when we see cases where the main cause or the main source of retraction is the anterior lamella, what can we do? So usually we have a conservative approach at the beginning, wait a few months with some massage. We can use steroids and 5-FU, especially in the upper eyelid, to kind of soften the scar. Use some hyaluronic acid fillers. Goldberg has interesting paper on that. And then after that, if it's not working, we need to decide to go and do the surgery. And we can use skin grafts, ectoplasties, flaps, and in the lower eyelid, and in the lower eyelids, can you help me with this? The mid-facelift. Okay, so let's start with one case. And this is a very complex case where the main cause is the anterior lamella. So in Portugal, we do receive a lot of patients from the ex-colonies. And this is a patient from São Tomé e Príncipe. He has 16 years old, and he has progressive frontal and parietal ulcerative lesions from 1 year. And he describes a previous history of a scalp trauma 2 years before. And he has a fungal soft tissue mycetoma. This is a very invasive and destructive infection that usually involves both the arms or the legs. We didn't find any case described with this presentation involving the eyelid and the orbit. So after a few months of treatment with antibiotics and antifungal treatments, we have the patient already stable, and we need to decide what to do. It also depends on what we are going to find during the surgery. So for sure we will need a graft, because this is mainly an anterior lamella problem. So we need to release all the scar, we need to release all the cicatricial tissue. I don't know how is the levator, but fortunately the levator seems normal. Now the posterior lamella is not involved, so I just do this mattress sutures to hold the fornix in position, not tightening too much. And then, of course, we go and go forward with our skin graft from the supraclavicular area. We need to overcorrect a little bit, as you all know. So we are harvesting the graft right now. And so, very important, we need to make it as thinner as possible, especially in the margins. We are suturing the graft in position, leave a tie over, and then this is the patient after 1 week with a dorsography, and this is the patient 1 year after the surgery with a good outcome, no lack of Thomas, and a good eyelid opening. Now, again, not all the anterior lamellar problems need a graft. You need to avoid the graft, especially in the lower eyelid, and especially in cosmetic cases, in these cases of post-blepharoplasty lower eyelid retraction. So we do have this patient. She did upper and lower blepharoplasty elsewhere. We need to manage expectations, of course. These are very complex cases. That would be another talk. But anyway, this patient should not be only approached for her functional problem on the lower eyelid, on the left lower eyelid. We need to see and address all the concerns the patient has. So I decided to do the revision of both the upper blepharoplasty, she has cystosis, so correct the ptosis, do transconch blepharoplasty. I always do transconch, especially here. I don't want to damage the orbicularis anymore. And with fat path resection, left mid-face pre-periosteal lift with the canthoplasty. You see there the foroproline lifting that SUF, and a right canthoplasty without canthotomy. I don't want to disturb that canthus. That looks quite okay. And so this is the patient 6 months after the surgery. She's not from Portugal. We do some online consultations, and 1 year after the surgery, she is quite happy. Now, let's continue. The middle lamella. Let's forget the middle lamellar retraction, because this was thought as being caused by blepharoplasty, but we know it. This has been studied by Maastricht. There is no isolated middle lamella scar. Usually it's a multiple lamella issue. So let's go directly to the posterior lamella, because usually it's an internal scar. And how can we manage these cases? So first, again, be conservative, wait, massage, steroids, find a few injections, some fillers might be an option. And then if nothing works, we can go straight to the surgery, a resection of retractors, both upper or lower, where is the problem, and spacers. I'm a huge fan of hard palate and cartilage only for facial nerve palsies. Now, classic patient, thyroid eye disease patient after strabismus surgery. This is a case where a hard palate spacer with a canthoplasty goes quite well. And this, I have 3 of these cases, young males with an upper eyelid unilateral retraction. He's a doctor. He has been studied for years with imaging and lab. No cause was determined in his cases, and for his upper eyelid retraction, that is quite stable. So the approach is quite similar to thyroid eye disease cases. So I did a recession of both Mueller and Levator through an anterior approach. Now let's get more complicated. This is a multiple lamella issue. So this is a patient with several limitations, several things here we need to take into consideration. He has a previous sarcoma that was reconstructed on both his upper and lower eyelid. On the right side, he has no vision. So his only functional eye is on the left side, which has a very severe exposure, neovascularization, and corneal opacification. And we need to address this. So first of all, many of our decisions are taken in the OR. So let's see what we find here. So he has still some residual tarsus and conjunctiva on the medial inferior area. So I did an incision in the mucocutaneous transition, do some dissection in the subcutaneous tissue, orbicularis in the medial area. And now I go and do a mid-facelift, subperiosteal. This is not, I cannot avoid a graft in this case, but this will give some support to his mid-face. Then I continue with a periosteal flap creation that helps me with the lateral part of the lower eyelid. So this will be both the posterior lamella and the canthus support. So I do that suture between the residual tarsus and the flap, and everything else needs to be covered with a graft. So this is the patient after the surgery, and this is the patient 1 week after the surgery, and he's going quite well in the long term. Now, loss of structural support, and let's finish with this, the sagging, the descent of the lower eyelid and specific. So don't forget, and you know this already. So lower eyelid position depends on several features: orbicularis tone, glow prominence, canthal tendon, and mid-face support. And of course, facial palsy. When you have a chronic facial palsy, this is not just laxity of the lower eyelid. If you do a dorsal strip, you will have this belly effect. So you need to manage as an eyelid retraction. So mid-face lift, auricular, cartilage graft, I need that very strong support, and lateral canthoplasty. And this is the patient later. And don't forget, glow position. Again, we know, especially in thyroid eye disease cases, that the decompression has a huge effect over the lower eyelid retraction, not so much the upper. But we know, especially in this case, what I did was the decompression. I know it will improve the lower eyelid retraction, but I give a little bit more of support to the mid-face with some fat transfer. And again, blepharoplasty, retraction, post-blepharoplasty, these are very complex cases, and you don't find only one mechanism, you find several mechanisms. And I think what is underestimated is orbicularis weakness. And I'm a huge fan, again, I always do a transconch. But I know there are many colleagues, they like the transcutaneous approach with very good results. Now, don't forget, you need to know how the orbicularis is innervated. This is very important to avoid the dangerous zones. So, know the wall innervation of the orbicularis, avoid aggressive muscle resection, preserve pretarsal orbicularis, and protect those perpendicular fibers of nerves that go parallel to the margin. And so these are the dangerous zones that you need to avoid when opening the muscle. The medial part of the upper eyelid, the medial part of the lower eyelid, up to 6 millimeters from the margin, and in the lateral part, from that lateral line of the canthus, 6 millimeters above and around 4 millimeters below. So not all patients need a facelift. In this case, we see fish mouthing, a good mouthing, a good orbicularis contraction. So this patient goes quite well with a lower eyelid retraction, retractor release, a canthoplasty. She doesn't need a mid-facelift or a spacer. This is different. This patient has very weakened orbicularis. So you don't address this easily. You need a spacer to give that support to the lower eyelid. And so this is the patient after a hard palate spacer and a canthoplasty. This is my algorithm. You can take a picture if you want. I just want to highlight the orbicularis weakness that we should evaluate in these patients after retraction, after lower blepharoplasty, because this changes our approach. When you see a very weak orbicularis, please avoid any cutaneous incision, any muscle incision. Give some canthal support. Many times you need to lengthen that posterior lamella with a spacer, and in more severe and extreme cases, the decompression may help you to make that eyelid lift a little bit. So as a summary, be aware, of course, of the multifactorial causes and natures of eyelid retraction. Always evaluate the underlying mechanism, blepharoplasty, be conservative, know your dangerous zones, and always check orbicularis strength, and again, managing expectations and also the pre-op evaluation is key. Thank you so much.
Thank you, Ana. I will present the next speaker, Dr. Lorenzano, OCT for preocular epithelial lesions, emerging roles, and future directions. And for the speakers, for the rapid fire session, please remember we have both of desks. Please use them. When one is speaking, the other is preparing, the next is preparing the presentation so we can gain some time. Thank you very much.
Thank you very much. Grazie Luigi di aver invitato. Mi sentite? Can you hear me? Mi riuscite a sentire? Allora, non vi sento. Qualcuno se mi dà un segnale?
Ti sentiamo Lorenzo.
Perfetto, grazie. Allora, thank you very much for having me here. Thank you for the Secretariat organizing this connection from remote. Unfortunately, I wasn't able to be with you today. Thanks to everyone listening to my topic, which is OCT for periocular epithelial lesions today. So what we will talk about today is recap on OCT in ophthalmology. We will have a little recap also on diagnostic tools in dermatology, and I will describe the LC-OCT technique machine, which is actually the key part of our presentation today, and of course clinical scenarios and reflections for the future. So we, as ophthalmologists, been working a lot with OCT for the last 30 years. So this is based on the principle of the low occurrence interferometry, which is similar to ultrasound, but is using light waves instead of sound waves, as we all know. This is a timeline which shows since the first 90s, the introduction of OCT with time domain, then we managed to get to spectral domain OCT in the 2000s, and now we are the latest cutting-edge source OCT, which is actually the state of the art. So you can see from the top the imaging rendering, and we went from 100 A scans to basically per second, and you can see from the top, to nearly between 100,000 to 400,000 A scans per second, and you can clearly see the difference. But it's not only about the scanning speeds, but it's also about the actual resolution that we have on this type of machines. We went from 10 microns to nearly 5 microns with the actual new machines. So if ophthalmology has been playing a lot with OCTs over the years, dermatology teams across the world have worked with reflectance and fluorescence confocal microscopy for different types of lesions on their patient OCT, and again LC-OCT just newly imported on the market. So for confocal laser scanning microscopy in reflectance mode, this is an optical microscopy technique. It's a low power near-infrared laser, it's around 130 nanometers, and it has a cellular resolution in real time. So for instance, elements like with high refractive index such as melanin, keratin, hemoglobin, and collagen fibers reflect back the light with this picture on the bottom left. It's divided in two halves. You can see the left side is a reflectance confocal microscopy, and on the other half, on the right side, you can see clearly this is a H&E staining, which we are all used when we are cutting out and liaising with histopathology. And you can clearly see that the two are quite astonishingly similar. So it's my pleasure to introduce to you today the line confocal optical coherence tomography, LC-OCT. The actual machine is an optical skin imaging technique, and it combines together both the technology coming from reflectance confocal microscopy and obviously the optical coherence tomography. So the OCT provides vertical imaging and of the skin with a resolution of 350 microns and a penetration depth down to 2000 microns, where instead the LC, the line confocal microscopy, gives you the en-face detail with lateral X, Y, and axial Z resolution, which is between 1 and 1.3 micron. So it's nearly isotropic to the cell. So this can generate a vertical and a horizontal section in real time and a 3D rendering within seconds. So this machine is particularly suitable, as you can see, for subtyping basal cell carcinoma, specifically for nodular, superficial, infiltrative subtypes, and can distinguish this can be done based on specific patterns. So you can see on the left a rendering of a confocal, horizontal, and face picture, which goes together with the vertical depth gained with the OCT. And again, this is LC-OCT combining microscopy, confocal, OCT, and AI. And this is a healthy skin structure, which of course delineates like a proper histopathology slide, I would say. So these are selected images for selected applications like BCC, you can see from the top, and this is the 2D, and this is the 3D rendering, below the SCC in situ, and the melanoma, just to give you an idea of how this machine is working. Again, other clinical application, on the left column you have superficial basal cell carcinoma, nodular basal cell, and infiltrating basal cell carcinoma. On the right, you can see clearly melanoma, Bowen disease, and inflammatory processes, in this case psoriasis. So what is interesting is that the last generation of this machine, which has been around for the last 6-7 years, over the last 2 years has introduced an artificial intelligence powered software in order to be able to diagnose BCC lesions. And as you can see from the left picture here, you have a yellow ribbon and a yellow stripe when the actual artificial intelligence is monitoring and studying a frank BCC lesion. And so you have a live BCC probability score and also a real-time heat map for explaining specifically where this is located on the lesion. On the right side, you can see BCC score 0, which is colored with a blue ribbon. So the artificial intelligence is trained on 600,000 images for the last 2 years, and it gets to 97% of diagnostic accuracy. So the next question I would like to make today is, can we consider this type of machine as a virtual Mohs surgery type of tool when we are delineating BCCs? So this machine is made of 3 modules. Module number 1 is the dermoscope. Then module number 2 is the soul of the machine, because it's obviously the probe that makes the acquisition, and the module number 3 is the artificial intelligence. So this is a short video which shows how the operator handles the dermoscope to start, with a lesion on the lateral brow here, you can see already marked. And the dermoscope is basically gaining a mosaic type of picture with ideally an unlimited field of view, so we can capture a lesion as big as we would like to. And it creates, of course, the mosaic picture of this. Then the operator takes the deep light probe, and that's when we are gaining the depth of the tissue. And as you can see from the bottom right, the probe is following the marking, and it's giving real time a blue line. The blue line is telling us that the pencil marking that we have carried out around the lesion is free of tumor, because it's blue, as we said before. So let me show you a case. This is the same case which was set for slow Mohs. And as you can see, the third quarter of this lesion is slightly yellow, and the probe is actually highlighting how this is 100%, it's scoring 100% for still BCC, where instead, when it's going around the blue areas, it's scoring 0. And this is to recap. So you can see 3/4 of the circle are blue, and the third quarter is yellow, detecting a positive area of BCC, which was confirmed at histology. This is another case. You can see a clear ulcerated lesion on the leg of this patient, and when we address the probe on top of the lesion, you can see clearly this is 100% BCC. This is Prof. Supra, which have kindly lended the slide to show how he's marking around the lesion. 3 millimeters, and he is actually creating the ellipse. And this is the rendering of our outer circle in blue, and the inner circle, there are still some yellow areas. So this is the macro specimen, which will be sent to histology, and you can see the 2 circles, one in the inner ring and one in the outer ring, showing 100% score in the inner ring and 0% score on the outer. And this is confirmed with histology. So this is the third case I want to show you, and I'm nearly finishing this. This case has been marked 3 millimeters perilesionally, and when we go inside the lesion, this is marking 100% BCC score, and at 0% when it's on the outer score, on the outer ring, which is showing that we can match this with the histopathology confirming the tool. So in conclusion, in the future, we might be reducing waiting times by using technology like this. We might be able to spend less in our public services, and this might help cutting costs on material waste, may save patients additional costs, minimizing the number of hospital appointments, and may enable earlier diagnosis, recognizing aggressive periocular tumors, may help especially medial canthal region lesions, and obviously present histology remains the benchmark, the gold standard for this. But in the future, we might be able to use this for preoperative diagnostics, especially for complex lesions. We may be able to help doing surgical planning. It can replace biopsy, in particular specific benign lesions that we want to follow in our clinics, and of course can create a preoperative map of the tumor margins, and it can be used for follow-ups and suspected recurrence when we have those scar retractions that we all have sometimes with reconstructions, especially peculiar ones, and especially patients also undergoing radiotherapy after excisions, or just to follow up these patients. Thank you very much.
Thank you, Dr. Lorenzo. Maybe this will be our future, very nice for the next case. Because we don't have time to discuss, we'll pass quickly for the case, and I ask for the presentations to be in both sides. The one that will be in the one side, and the other one be in the other side to start soon. Annunciata will talk about the impact of eyelid position biometry and IOL power calculation.
For the technician support, please, we lose our left monitor. Could you please repair this?
Hi to all, and many thanks to Dr. Colangelo for inviting me to speak at this Congress. I am a refractive and cataract surgeon, so we will speak today about the impact of eyelid position on biometry and IOL power calculation. There are 3 main mechanisms affecting biometric accuracy. The first one is mechanical effect, such as in ptosis and dermatocalasis. There is a tear film effect, such as in ectropion or entropion, and an orbital effect, such as in thyroid eye disease. Before speaking of each one, we have to remember that the eyelid exerts continuous pressure on the cornea that is predominantly vertical and isometric force. It influences the corneal curvature and astigmatism, and the effect is dynamic, in other words, blink dependent. About the mechanical effect on the corneal shape, in ptosis and dermatocalasis, the eyelid pressure alters the corneal curvature, and the cornea, we have to remember, that provides the 70% of the eye total refractive power. So there is an induced astigmatism and active sheaths, and even if it's not linear, there are greater changes in moderate severe ptosis. The mean keratometric change after ptosis repair is from 0.3 to 0.7 diopters, and so that means that there is half diopter refractive error after the procedure.
It's very important to remember that ptosis or dermatogalaxis causes with the rule astigmatism. So after the procedure, we can have against the rule astigmatism or an hyperopic shift. And so the patients will not see very well from the near and from the distance. And very important is that, as we saw that the pressure on the cornea is not symmetric, often we will see a change in the axis of the astigmatism. So if we have just already implanted a toric IOL in the patient, there will be a change in the axis of astigmatism. And only 10 degrees of axis misalignment results in 30% loss of toric effectiveness. Regarding the second mechanism, the tear film, it's very basic, but ectropion or entropion alter the tear film distribution. So there is an instability of the tear film that increases the surface irregularity. So there are high-order aberration, reduce the repeatability of keratometry and topography, and so the biometric is very unreliable. The third mechanism is the orbital effect, such as in thyroid eye disease. Thyroid eye disease, as we all know, causes orbital tissue expansions that increase the orbital pressure and could cause globe displacement. So there are potential changes in the axial range and biometry. In several studies are reported changes from 0.1 to 0.3 millimeters that can lead up to 1 diopter's refractive impact. And it is also important to remember that during the active phase of the disease there is high variability. So, which are the take-home messages? Treat eyelid and orbital disease first and repeat biometry after the stabilization. Then proceed with cataract refractive surgery, and this is critical when we use premium IOLs on toric ones. Of course, there are some exceptions, such as in advanced cataracts may require prior surgery. And the most important advice is to be friend with your oculoplastic surgeon. And in our team, we have Dr. Colangelo in our clinic that is very ready, always ready to give an advice to us. Thanks.
Thank you, Doctor. Dr. Morchet will talk about botulinum toxin doses management, 5 years practice. The next one, Aimino, please be there.
Okay, so I've been treating for the last 5 years patients by Botox, not for wrinkles, but for ptosis. And we can see in these photos different degrees of ptosis fixed and corrected with Botox. So the technique is somehow simple. We have 3 injection sites in the pre-tarsal orbicularis with 1 to 2 units per injection site. And we can see that the middle circle is kind of bigger than the other one because this is the safest place. If I need to increase more units, then I would safely inject it in this middle area, not medial and not lateral. The concept is somehow also simple. We try to reduce the tone of the orbicularis muscle, so we create more of a balance between both muscles, or we allow the levator palpebral to do its job in a better way. So the indications are patients refusing surgery or those that do have very mild degree of ptosis that it is not very necessary to do the surgery, mild asymmetry, complicated cases with long history of surgeries, and you can fix ptosis that has happened already from previous Botox injection in the forehead or whatever area. Advantages, it's very safe and simple, it's effective in 95% of the cases, and it lasts between 9 to 14 months, which compared to the regular longevity of Botox, it's considered pretty long. Side effects, transient tearing, it's very minimal, and it usually lasts 7 to 14 days. It showed to be not very effective in 5% of the cases, and worsening of ptosis happened in 2 cases, and later I can say why those cases. So these are more complicated cases. This is a lady that she had done blepharoplasty elsewhere, and she had already an attempt to correct the ptosis in this eye, and then she came to me and I suggested Botox. So this is the result after Botox. Again, this young lady had a long history of trials to correct her eyelid through surgeries, and then we can see the result. Another example of a lady also had surgeries elsewhere to try to correct her droopy eyelid, but this is the result that we can get with ptosis. Again, we can see even the compensated elevated eyebrow, and now everything is well rested just by Botox. This is a special case because this lady came to me 3 weeks before her wedding after a friend of hers suggested her that she needs to do some forehead Botox, and then this after photo is just 1 week before her wedding. I think with a good makeup artist she can pass the day. This is also a young lady. This is my youngest patient. She's 16 years old. Her parents were so scared, and she had so many insecurities from the sleepy look of her eyelids. And now, after the treatment with Botox, I think she's much, much better and much happier. So the take-home message, it's a very safe, reliable, and effective procedure. It does not definitely substitute surgery, but it's a very useful tool in practice, and repetition of the technique showed no affections on the eyelid's integrity. Thank you.
Thank you, doctor. Now, Dr. Irene will talk about ptosis and blepharoplasty.
Good morning, everyone, and thank you very much for the invitation. Not my presentation.
Sound.
Please try to repair the left monitor.
High middle, please. High middle.
Yes. Good morning, everyone. Thank you for the invitation. Today I will talk about ptosis and blepharoplasty and whatever they could be performed as a single procedure. Blepharoplasty is a common aesthetic procedure that improves eyelid
Please talk
appearance.
near. Talk near. Talk near the microphone.
Okay. Sorry. Blepharoplasty is a common aesthetic procedure that can improve eyelid appearance by removal of excess skin and fat. However, it does not correct ptosis, which is often under diagnosis, and it can affect surgical outcomes. The key point is that preoperative recognition of ptosis is essential for the success of blepharoplasty. In fact, blepharoplasty will even worsening on unmasking eyelid ptosis. Preoperative diagnosis is important to identify ptosis, which might otherwise become evident only after excess skin removal. During clinical evaluation, it is important to assess eyelid position, symmetry, and levator muscle function in order to correctly identify the type of ptosis, because that allows us to choose the proper surgical technique to avoid complication. So there are different surgical techniques for correcting ptosis that can be performed during blepharoplasty as well. Aponeurotic surgery is commonly used in older patients with normal levator function and changes in eyelid crease. It involves advancement or refastening or resection of the aponeurosis. Levator surgery is usually used in congenital ptosis with poor or moderate levator function, and it includes refolding or resection of the muscle. Another option is the Muller and Blasters resection that can be used in menial ptosis with good levator function and by a conjunctival approach, but it carries a small risk of suture-induced keratopathy. Another option for young patients with minimal ptosis and a positive phenylephrine test is Muller plus conjunctival resection. These techniques preserve tarsus, reduce complication, and rarely leaves residual ptosis. So, combined approach, blepharoplasty plus ptosis, has several advantages. In fact, if ptosis is not correct, we may have postoperative asymmetry and may require revision surgery. On the other hand, with combining procedure, in one single surgical procedure, we may assess better aesthetic harmony and a faster recovery. In this video, they demonstrate a minimally invasive technique for reinforcing the aponeurosis by the application of a single suture at the level of the pupil, passing by the tarsus and the aponeurosis, as we can see. This is the results with only one suture. So, in conclusion, the take-home message is simple. Ptosis must always be evaluated while undergoing blepharoplasty. Combined surgery often improves outcomes, and preoperative assessment is crucial. Thank you very much for the attention.
Thank you very much. Dr. Bernotti will talk about the periosteal flap surgery.
Buen día. Bueno, yo vengo de Chile, mi español no es muy bueno, pero mi inglés es mucho peor, así que con la venia autorización de Luigi voy a poner en español. So I speak Spanish, but the slides are in English. Ya, seguimos avanzando. Bueno, el uso del periósteo habitual que tenemos es el reemplazo de la lamela posterior y también como un elemento de fijación, como la cantopexia, por ejemplo. Y aquí viene yo le hago un uso adicional que lo uso como suspensión en casos de tosis con pobre acción del leador o con una alteración anatómica de importancia. Aquí tengo un esquema de una cráneo, una órbita y una cinta de papel que simula el periósteo. Y básicamente la técnica consiste en eso que ustedes ven ahí. Por fuera del paquete supra, hago en el borde de la órbita, hago una incisión al periósteo y diseco hacia la órbita aproximadamente 1 centímetro. El ancho de esto más o menos unos 5 a 2 centímetros. 1 centímetro hacia ¿No se me escuchó? Sí. Pero es lo que están viendo. Incido el periósteo en la órbita, por fuera del paquete supratroclear, y 1 a 5 2 centímetros y entro hacia la órbita como 1 centímetro. Y hago las incisiones de descargas laterales. Esa es más o menos la técnica y esto es muy fácil, se llega, como toda la cirugía, se reborde. Y después lo fijo con 2 o 3 puntos a la superficie tarsal anterior. Eso es. Hago una sección mínima de piel y dejo unos puntos de flor por unos días. En esta técnica es suficiente dejar unos 2 milímetros bajo el limbo porque el periósteo suele ser muy estable y la verdad que en el tiempo quirúrgico, en lo que llevo experiencia, no me baja de la posición inicial de la cirugía. ¿Por qué hago esto? Bueno, lo hago porque a mi juicio, estoy convencido de que el eje fisiológico y natural de la aponeurosis es horizontal hacia el vértice de la órbita. Y yo creo que esto por lo menos lo simula un poco más porque no queda tan alejado del vértice, digamos. No queda sobre la superficie frontal y ahí voy a explicarles por qué. ¿Qué hago yo actualmente? Bueno, a raíz de un caso, ahora lo que hago es, la doctora Cardoso algo explicó parecido a esto, lo que hago primero es una resección idealmente supramáxima, aunque tenga mala acción del leador, y lo que logro corregir lo veo en el minuto quirúrgico y ahí mismo después si lo necesito, que habitualmente es muy mala acción del leador, si se necesita, hago el flap de periósteo para corregir lo que me queda a diferencia. Con esto disminuyo la posibilidad del lago oftalmo. Bueno, en general la anatomía normal, aquí le hice un esquema, como ustedes pueden ver, tiene acá, va el leador y está el Windal. Cuando nosotros hacemos supramáxima, el Wilner lo separamos de esto, lo cual yo creo que es un factor que favorece porque el Wilner más que nada es un freno a la acción del leador hacia atrás, para que no se nos vaya tan atrás el párpado. Y en las cirugías actuales de suspensión, todas lo que hacen, tienen un eje que parte de una superficie que está anterior a la superficie del tarso. Así que todas las cirugías, todas van a separar un poco el párpado del bulbo ocular. ¿Cómo influye eso en la distribución lagrimal y la superficie ocular en el tiempo? No lo sé, yo creo que hay que investigar un poquito más de eso. Cuando nosotros hacemos la cirugía, ¿cierto? Se fija ahí una parte del tarso y pasa lo que les digo. Si yo fijo más pegado al borde del tarso, indudablemente lo que voy a hacer es invertir más el párpado, pero voy a separar menos del bulbo ocular, lo cual es un factor favorable. Y si es al revés, si me pongo más hacia el margen palpebral, voy a invertir menos, pero voy a separar más el párpado del bulbo ocular. En definitiva, la ventaja que creo que es más fisiológica en cuanto a las otras técnicas, la desventaja es que aún no tengo mucho tiempo de experiencia, creo que es un poquito más la oftálmica, pero se puede evitar porque se subcorrige, como es más estable. Y aquí tengo unos pequeños casos que es importante que se los muestre de la cirugía. Como ustedes ven, no esta es la oftálmica de un niño que se hizo unilateral. Esta, perdón, la fotografía no es muy buena, pero la mandaron de afuera. Tenía una oftalmoplegia externa progresiva y aquí subcorregí, pero lo suficiente para que pudiera tener el eje espejado. Acá esto, cuando fui al sur de Chile, una colega le dije que a ella hiciera la primera cirugía en un hospital y tuvo miedo de corregir más y quedó un poco hipocorregida. Este es un paciente que tenía un trauma severo, tenía múltiples cirugías, tenía telecanto, todo, y bueno, en la cirugía misma, él solo quería tener el eje visual despejado y ver con ese ojo porque tenía buena huesa visual. Y bueno, aquí usé el flash de periósteo, definitivamente no encontrábamos tarso nada, así que lo unía al tejido fibroso y logramos el efecto de levantar el párpado y dejar al paciente contento. Y esta niña, perdón, se borró una foto. Bueno, esta niña tenía una tosis importante, tenía una acción de leador de 5 milímetros. Ella me inspiró en cambiar la técnica. Entonces dije, voy a entrar a una resección supramáxima suficiente. Y cuando entré, la poliurosis era un desastre, grasa. Así que resequé lo que pude, me uní de lo que pude al tarso y me di cuenta que me levantaba, pero me hipocorregía. Y ahí agregué el flap de periósteo. Y yo creo que esta técnica es mejor porque respeta más el eje fisiológico. Gracias.
Thank you, Dr. Bernard. Now, we invite Dr. Silvita. He will speak about ptosis frontal flap to investigate the impact of binocular vision disorders on functional ID outcomes after frontalis frontal.
Buongiorno, io per non fare sentire solo il collega parlerò invece in italiano e oggi ho il piacere di presentare uno studio dal titolo Functional Impact of Amblyopia, Strabismus and Anisometropia on Ptosis Surgery. Lo studio nasce dall'osservazione clinica di un particolare tipo di apparente ipocorrezione in pazienti affetti da ptosi con comorbidità quali ambliopia, strabismo e anisometropia. Queste condizioni, che sono distinte da un punto di vista cepatogenetico, in realtà possono essere accomunate da un unico epifenomeno funzionale che abbiamo chiamato Ptosis Related Imperfect Binocular Fusion. L'obiettivo dello studio è quindi dimostrare tale correlazione e indagarne i meccanismi cepatogenici. Lo studio è uno studio retrospettivo osservazionale su una mostra di 34 pazienti di età pediatrica affetti da ptosi monolaterale congenita, operati tra il 2023 e il 2024 alla medesima equipe operatoria di flap frontale bilaterale. La mostra è stata divisa in due gruppi, un gruppo 1 affetto da tale comorbidità di 14 pazienti, un gruppo 2 di 20 pazienti non affetti. Sono stati valutati MRD1, apertura palpebrale, funzione dell'elevatore dei due occhi nel preoperatorio e nel postoperatorio immediato e a 6 mesi è stato rivalutato MRD1, apertura palpebrale e delta AP, ovvero la differenza di apertura palpebrale, in modo da avere un parametro che significasse la simmetria di esito in maniera indipendente rispetto all'apertura palpebrale target, che può cambiare per motivi etnici o individuali. Ora, i due gruppi sono risultati omogenei nel preoperatorio, eccezione fatta dell'MRD1 preoperatorio, più basso nel gruppo 1 come da letteratura. I risultati nell'immediato post-operatorio non vedono differenze statisticamente significative, vi è una leggera simmetria maggiore nel gruppo 2 e questo è relativo a una ipercorrezione della palpebra ptosica che si esegue durante la chirurgia, come la letteratura. A 6 mesi abbiamo un'inversione del trend, un aumento della asimmetria tra le due palpebre con valori statisticamente significativi, maggiori nel gruppo 1, confermati sia da un'analisi di regressione semplice sull'intera mostra e suffragati inoltre da un'analisi di regressione multipla che coinvolge anche MRD1 preoperatorio e funzione dell'elevatore. Dimostrata tale correlazione, la parte più importante è una pseudo ipocorrezione molto particolare, molto variabile, difficile da studiare e come vedete in downgaze il lead lag è perfettamente simmetrico. Cosa vuol dire? Che non vi è una ipocorrezione chirurgica, bensì un fenomeno funzionale. Questo fenomeno funzionale nasce da un fenomeno chiamato self-blocking, un fenomeno neuroadattativo. Tutto nasce dalla visione binoculare imperfetta. I piccoli pazienti, per ridurre la confusione visiva legata alla chirurgia della ptosi, cercano di ritornare alla condizione di ptosi tramite un meccanismo neuroadattativo volitivo incosciente. Ora, come possiamo dimostrare quanto detto? Perché questo tipo di pseudo-ipocorrezione è suscettibile a trattamento conservativo di tipo ortottico, tramite patching alterno e corretta refrazione, come possiamo osservare anche in questo video che spero parta. E con questo io concludo, mi dispiace che non sono riuscito a dire tutto quello che c'è da dire, ma il tempo era quello che era. Grazie.
Thank you, Doctor. The next presentation is Kazanavi, correction of recurrent ptosis.
Hello, everyone. I would like to present our work on corrections of functional aesthetics using the frontal flap technique on recurrent ptosis.
Micro.
Yes. Well, the purpose of this work was to demonstrate the effectiveness of the frontalis flap technique in patients with recurrent and multiple operated congenital ptosis in whom extensive scarring of the skin, orbicularis and levator muscle and conjunctiva complicates further surgical correction and functional activity of the upper eyelid. Of course, these were most of my patients that came to the office after many surgeries, other were. The study started in 2021 and took about 6 months to complete 10 surgeries. These were the first patients we had. The surgeries were performed in 2 different cities in Russia. Until 2021, no one in the Russian Federation had performed in regular basis the frontalis flap technique for ptosis correction. So we choose 10 patients with congenital ptosis. All of the patients have had 1 or more previous surgery with different techniques without achieving a satisfactory either functional or aesthetic results. Prior to surgery, we evaluate the functionality of the levator muscle and the previous post-surgery scarring of the anatomical structures. So previous techniques in anamnesis, we found silicone sling and mulerectomy in one case, multiple levator resection in 2 cases, levator resection and silicone sling, 3 patients, and silicone sling on 4 patients. This is the most used technique in the silicone sling is the most used technique in Russia. So here we have some pictures of the interoperation period, the silicone, we extract the silicone. Here I found the marcellin mesh, what we extract. So the evaluation of all the patients include eyelid height, contour and symmetry, functional improvement, aesthetic outcome, and corneal status, of course. Frontalis flap correction was performed in all these cases. So the surgical concept is the vascularization of autologous frontalis flap, independent of the levator function, effective in heavily scarred eyelids, and provides a stable eyelid elevation, improves the contour and symmetry. This is a video. How do I do to? Oh, yeah. So here we check the elasticity that we choose for the frontalis flap, and we have already our tarsus prepared for the implantation insertion. Some clinical example. This is a boy with after 2 levator resections, and lady, young girl with silicone after silicone sling. In both cases, we operate both eyes. Well, results. All the patients demonstrate significant improvement in upper eyelid function, a stable eyelid elevation, very good aesthetic outcomes, and no visible scarring. This is a patient with 6 operations prior our frontalis flap operation. So, no post-operative corneal complications were in this case, no major adverse events. This is some of our results, some of mainly both eyes. We always check how our babies or how our patients sleep, and we have control on that. And for the conclusion, the frontalis flap technique is safe and effective for the current congenital ptosis, provides reliable functional restoration and excellent aesthetic outcomes, even in extensively scarred eyelids. Careful post-operative corneal monitoring remains essential. And I would like to get 1 more minute to tell you that since 2021 we have performed surgery for with the frontalis flap technique in more than 430 patients with congenital and acquired forms of ptosis. We have had only 63 post-surgical complications with good results after treatment, 6 surgical secondary corrections of upper eyelid, and only 4 serious corneal complications, 2 of them ending with corneal transplantation. We have taught the technique to many specialists in 4 different countries. So, well, this is my reference, and I would like to thank Professor Colangelo for the invitation. I would like to thank Dr. Ramon Medel for showing me this technique. Well, and I hope to see you soon.
Thank you very much. Some advice, please. We have a 30-minute delay, so we won't have ask questions session. All the presenters will be pleased to respond to your questions during the lunch. And for the speakers who have not charged their presentation for tomorrow, please do it today so we can start early in the morning. And for those who comes early, Dr. Colangelo will give a Mercedes-Benz. Thank you.